Thank you. Hi, everybody. Right after lunch, what a better place to be seated than you guys right after a little, what is those little chocolate wafers and dessert on the tables. I'm really excited to be here to bridge the afternoon discussion into obviously something everybody on the panel is passionate about, but hopefully all of you are as well, which is digital health, technology, and innovation, and how it's changing really healthcare globally. Just by way of hands, I want to get a sense of who's in the room. How many people in this room are entrepreneurs? Wow, fantastic. So this got all the entrepreneurs who are here in this room. Investors in healthcare? Great. Government?
Wow.
Payer, provider, pharma, industry? All right. Students? All right. Anybody I missed? Patients. How many patients? Everybody, right? Everybody, exactly. So what I thought I would do before asking each of my fellow panelists to introduce themselves is do a little bit of a setup about what we've noticed really over the past 7 or 8 years, not only coming at it from an entrepreneur's perspective, but an investor perspective, a patient perspective, government perspective, and an industry perspective. I have some slides. I don't have a clicker. They told me just to tell you guys in the back to bring up the first slide. This is really something that I think for anybody who's been watching over the last 20 years, every other industry get transformed by the internet and technology can see many of these things kind of as any one of them transforming an industry. In healthcare, these are 5 macro conditions that are all converging at the same time. You've got, of course, business model change, not just ushered in by the Affordable Care Act 7 or 8 years ago, but all around the world, how healthcare is being paid for, who's paying for it, who's approving it, who's taking care of you, and the reimbursement model is undergoing rapid change. And so that's kind of one big condition. But if that wasn't enough, you've got the urgency of chronic disease, aging cost, coupled with the fact that we're living in the golden age of entrepreneurship. It's never been easier, never been faster, never been more easy to access capital and resources than it is today. And then if that wasn't enough, the advent of all of the digital health devices and sensors, the Apple Watches, all the phones we're carrying, all the sensors that are now in abundance, creating new data sets. And it's happening around the world all at the same time. And so there's a global conversation. So there has never been this alignment of macro conditions. So over the past 7 years, there's been an influx of capital invested in what is called health tech or digital health. If you can bring up the next slide, there's been almost these moonshots that entrepreneurs are now working on that even just a couple of years ago seemed impossible. Access to care, no matter where someone lives, no matter how much money they make, curing disease and ending cancer. Vice President Biden, during his administration, launched the Cancer Moonshot and started opening up the idea that we can actually work on ending cancer as we know it. Women's health, children's health, nutrition, happiness, longevity. These are big, massive health moonshots that entrepreneurs all around the world are working on. We're actually at Startup Health tracking 10,000 startups around the world. And one measure of that is funding. When you look at the last 7 years, since 2010 when we began tracking it, if you can go to the next slide, the amount of capital being invested by everybody from venture capitalists to private equity to the payers, providers, and pharmaceutical companies has over 10x the amount of capital on an annual basis. This year will easily surpass last year, which was, of course, the biggest on record. But when you see this kind of exponential growth and you look at where it's actually coming from, this is the part that should shake everything up, which is, next slide, all around the country, in every city, innovation is attracting funding. In other words, it's no longer relegated to Silicon Valley or Boston. And when you actually branch out even further, next slide, and you look globally, you're seeing innovation in every corner of the world, which means that people are sharing what works and what doesn't work, who's helpful and who's not helpful, and very quickly ushering in the reimagination of healthcare. And so At Startup Health, we launched 7 years ago a 25-year mission to really invest in this global army of entrepreneurs all around the world who are working on health moonshots. The people that are to my left and to my right on stage represent, or 3 of the 4 represent startups that have emerged over the past several years. None of them could have existed 5 or 10 years ago. None of them could have attracted not only the capital but the talent, nor even leveraged the technologies that we now have in our pockets and at our disposal. And then Joel's here to represent the government side of what easily for entrepreneurs is one of the biggest hurdles that they're facing in innovating, because in every other sector, you don't even need to care about the government or big bureaucratic companies that control the industry. So if you're in finance or education or media, a lot of the disruption is coming from the bottom up. In healthcare, we have to collaborate. So startups have to collaborate with payers, providers, pharma. They have to collaborate with the government. And so this discussion is about how entrepreneurs and the startups and the organizations that they're all working on are not only reimagining where we're going, but are seeing things that, as patients, I think would give us hope, as industry leaders would give us hope, and as entrepreneurs, without a doubt, the most exciting time to be doing this in the history, I think, of not only the world, but just embarking on something that within our lifetime is going to seemingly achieve impossible goals. So with that, I'm going to ask each one of my panelists, fellow panelists, to introduce themselves, but not just who you are, the company you're at, and why it was created. Start with you.
Hi, everyone. You can hear me okay? Great. My name is Sara Wajnberg. I am the SVP of Product at Oscar Insurance, which is based in New York. I have been at the company now for 5 years. So we did actually start 5 years ago, but just in the beginning of this wave you're describing. We first launched and started providing insurance coverage on the individual market in 2014. Oscar is a technology-driven, which is rare, consumer-centric health insurance company. And so the idea was to really enable, empower consumers to get the information they need to be able to navigate the healthcare system more efficiently. And we use a best-in-class digital and human experience through our customer service teams to really create an engaged relationship and kind of act as the entry point for consumers to navigate healthcare in an efficient way. That's me.
And why, I asked this question on the prep call we did. Why did you join Oscar?
So I had come from a background working mostly at other startups. So, Oscar now just hit over 1,000 employees, and it is by far the largest company I have ever worked at. And I had worked primarily in e-commerce and really wanted something a little more mission-driven, a little more aspirational. And I also had exposure to healthcare from various angles. For example, many doctors in my family. So I had seen a lot of different sides of the pain of working with insurance companies in particular. And I was very excited and passionate about the idea of really changing the way insurance works in the US and making it less painful for all parties involved, as well as really enabling the consumer in healthcare and trying to make it more like the experience they have shopping for anything. So that was really attractive to me and why I joined the company.
Fantastic, thank you. Katie.
Great.
Different kind of company, different part of the industry.
Also in New York. So I'm Katie Jacksheimer Agarwal. I'm SVP of Operations and Finance at Maven Clinic. Maven is a digital clinic for women. So what that essentially means is that we offer family benefits to employers. And so employers then offer Maven to employees, covering all aspects from fertility, egg freezing, maternity, return to work. So our goal is really to support women and families throughout that whole spectrum. At our core, we have a network of 1,200 providers, telemedicine providers, who cover areas like obstetrics, nurse practitioners, return to work coaches, lactation consultants. So really trying to return women to work after having a baby in a spot where they feel mentally and physically ready to be able to return and succeed. Maven was created out of an experience of our founder, Kate Ryder, where she at the time noticed a lot of her friends going through challenges related to fertility and pregnancy and not having the support that they needed to be able to succeed both with their health and then also in the workplace. I joined Maven about 1.5 years ago, largely for also personal experience. We just welcomed our own baby into our house, but also it was a relatively long journey from fertility through pregnancy, and then now in my own experience returning to work and understanding the challenges that women face from pumping on the train on the Acela down here to figuring out how to balance both being at home and being a working mother.
Fantastic. Lots to discuss. Matthew.
Matthew Stoudt, I'm the CEO and co-founder of a company called appliedVR, and we're focusing on revolutionizing pain management in the US and around the world. Alex Azar this afternoon talked about the opioid epidemic, and one of the other stats, just to tie it home for you guys, is we're 5% of the world's population, and we consume 85% of the world's supply of opioids. If you knew nothing else, that there alone tells you that something is wrong with the way we're doing things here. And so we are on the forefront of bringing in a non-pharmacological alternative that has over 30 years of history behind it, but only now because of the evolution of the revolution in technology and computing processing power that we're able to actually make this scalable and affordable and bring it into everyone's doctor's offices, hospitals, or homes. And by the way, I don't come from healthcare at all, and I wish I would have known something about healthcare when I got into this, because I never would have gotten into it, because it is the craziest space I've ever come across in my life. But now that I'm in it, I love it.
And the reason you started it?
So my last company, if you guys ever go to a gas pump and you see those awesome flat screens at a gas station that advertise you when you really don't want it or need it, that was me, and I'm sorry. And I'm trying to make amends for that, and I'm a big believer in making an impact in this world, and this is my opportunity to make an impact.
Fantastic. Thanks, Matthew. And last but not least, Joel.
Yeah, Joel White. I'm the president of Horizon Government Affairs. 11 years ago, we started an organization called Health IT Now. Health IT Now is a coalition effort of 75 different organizations. So startup companies like Omada and Evidation Health and Call9 and Capture Proof, who are just starting out trying to make a difference in healthcare and disrupt, to mature companies like IBM, McKesson, Aetna, Verizon, and others. But our main cohort of groups are patient organizations and employer groups who came together around the idea that health IT and data could be applied to healthcare to make it better and more efficient and effective. And the reason I got into it was I spent 12 years on Capitol Hill writing a lot of the laws that you all are living under, like Medicare Part D, and if you have an HSA, it's one of the laws that I worked on as well. And what we saw was government programs that were really unresponsive to advances in technology that could improve the lives of people at a very practical level. And so I wanted to dedicate my time and effort to knocking down those laws and knocking down those barriers, reforming those regulatory processes so that we can integrate technology into care so that people's lives are better.
So, Joel, you obviously get to have conversations every day delivering, I guess, both bad news to entrepreneurs that come in bright-eyed and bushy-tailed, I call it blissfully ignorant, about what they're up against. What is today different about that conversation than it might have been, let's say, you said you started 11 years ago, 10 years ago?
Yeah, 10 years ago, basically where we're at a Medicare program that was $500 billion spent every year. We had about 70% of large employers who used telehealth on a regular basis. That number is now 90%, so more people are adopting telehealth as a solution on the private side. But we still have only about 1% spent back then in the Medicare program on digital health care, and now that number is about 1%. The reason for that is because we have to wait for Congress to change the law to pay for things like digital health, and that hasn't changed in that 10-year period. What is changing just this year, Congress passed some laws that said, okay, we want to enable value-based payment arrangements and manage Medicare type arrangements. Say, like, if you're at risk, then it's okay for you to use whatever tool you want to improve care, because what do I care if you lose your shirt on adopting a telehealth tool? I'm going to pay you the same amount. That's not true in fee-for-service. In fee-for-service, if I adopt an expensive technology, I blow the doors out on volume, I'm going to spend a lot more money. So I think Congress is now recognizing that we can shift to a value model and adopt technology that's going to improve the lives of everyday patients.
So that theme of 10 years ago, I want to move back to Sara, because could Oscar have existed 10 years ago? And more importantly, what are you doing today that you could have never done before. And that's going to be a lead-in, obviously, as we go to the future. But I think it's really important. One of the themes of this panel was about the last decade. And I just think people underestimate how much has happened in the last 10 years.
Well, first of all, Oscar was founded mostly originally because of the ACA. So that's a very simple way of saying likely not. It probably wouldn't have been founded prior to that. And the ACA was just a catalyst for the belief that insurance and healthcare was moving in a more individualized direction. And so since we initially launched, we have added additional products to the portfolio, like, for example, small employers, where we still have a direct relationship with the employee and the consumer. And then in 2020, we are launching in Medicare Advantage as well, where there's that direct relationship with the consumer. And so we really believe that the future is individualization and that people will be empowered to make more choice over time. And so, maybe we couldn't have done that 10 years ago, but that's definitely the way things are moving in the future. Things we can do now that we maybe couldn't have done then from a technology perspective. So for example, we have a step tracking rewards platform where people can use the native either iOS Apple Health Kit or the Google Fit app and basically track their steps. We give them certain goals, and if they hit their goals, they can get rewards in Amazon gift cards. Those are things that are more recently developed, and as people come up with more and more technologies, we were just talking about the EKG thing that Apple is developing, there's going to be a lot more opportunity for carriers and for anyone who's trying to promote health and wellness to be able to piggyback off of those things to collect more data and to help intervene in the care of our members. So we definitely keep a close eye on the evolution of those technologies and how we can integrate with them and partner with those people. Our aspirations are to eventually serve as a kind of marketplace for our members to be able to interact with those types of other technologies that are being developed.
So I'm going to flip it back over to Matthew. Same question around, VR, right? So we're reading about it a lot now in other industries, gaming and other areas. Tell us about what's only possible today that even 5 or 10 years ago was not possible.
So it's really about scalability in the world of VR. So actually, VR has been around for over 30 plus years. And one of the very first seminal studies that was done was in pain management for wound victims going through debridement, which is one of the most painful things you'll ever experience. And even back then, it was an innovative researcher identified that opioids, which were used as the abatement tool back in early 1990s, had terrible side effects and only mildly effective. So we had this insight that pain is something we like to think of as at the point of contact, but we have pain receptors in the brain. If we can overwhelm those and get you to displace your focus, we can get you to feel less pain. Did a test control demonstrating that VR outperformed opioids. And that launched over 100 plus clinical studies over the last 30 years, all demonstrating that very same thing, but the technology weighed about 50 pounds, cost about $100,000, and was tethered to big machines. And so it lived in the world of, isn't that interesting? So now fast forward where literally, if you have a cell phone, you can deliver something that is, if you put a headset around this, that is more immersive, has more processing power than what was done back then.
Get the whole yellow theme going here.
Yeah, I know, we're trying to work it, right? And Milken was nice enough to give us yellow books. So. But we're at a point now where we can actually bring this out, we can make it scalable, and we can make it affordable, whether it be from an insurance reimbursement perspective, or actually where I think the big impact is and kind of goes with what Sara was saying about empowerment, is how do we help people out in their homes, right? Because if you're really going to think about where you get an alignment of payer, patient, and provider, which is what you ultimately need to find success, it's about doing things that can help all three of those. And so if a patient can do something from the comfort of their own home and either get it cared for or taken care of from a payment perspective, or push to them from a provider perspective, it helps reduce overall resource utilization and create a better quality of life, which I think is what we're all looking to do here.
So cost coming down was the big thing.
That was the number one, cost coming down in form factor. So I view technology as friction. Every day in every way, this friction is getting easier or less and less and less. So the fact that you can actually have a watch now that tracks your EKG, as we were talking earlier, where you don't even necessarily know that it's on you, or a Fitbit that you walk around with you that's providing all this great data that you never even think about. In our world, putting on a clunky thing that sits on your head, there's still some friction around that, but every day in every way, that friction is getting less.
And what do you think the tipping point is going to be to where everybody, how many people have experienced virtual reality in any?
That's pretty good.
That's pretty good, right?
Yeah.
Well, everybody came in, like the early adopters.
Yeah, fair.
But what's the tipping point?
The tipping point, quite frankly, is, we'd say this, for us to be able to get this to everyone's home and be able to deliver these great therapeutic interventions, it's about doctor prescribed and patient used. And so I go back to that, one of the technology, the charts that you had earlier on. You're looking at all the different elements that you've got to bring in order for this to be effective. And the thing that we have behind us, sadly, but to our benefit, is this opioid epidemic and pain crisis. And everyone, from the payers to the patients to the providers to the government, they're all doing everything they can to try to bring into to existence in a scalable way these new tools. And so for us, most directly, it's about getting reimbursement for something like this, because that's where you get velocity and that's where you get distribution.
That's why we all need Joel.
Exactly.
Katie.
And Sarah.
Thank you.
Katie, same question. Could Maven existed more than 5 years ago? And then, where is that tipping point where all of a sudden it's not going to sound like a crazy idea anymore?
Sure, yeah. So Maven was founded in 2014, which is approaching 5 years ago, but we learned a couple things from that experience. One, we've shifted our business model from more focus from B2C to a B2B model where we're selling through employers. And we've also taken advantage of the fact that telemedicine laws have actually significantly changed in the last few years too. 5 years ago, across the board, we couldn't have established the first patient and provider connection in telemedicine for a handful of states, and now we are able to do that with, of course, making considerations for exactly how we go about. So, and the technology piece as well, I think we've gotten obviously much stronger on it as we've continued to learn and continue to take advantage of new opportunities for remote monitoring and just continuing to check in and emphasize engagement. I think all of that is true, but also at the core too, we're using a lot of the medicine that we've known about for decades as well. So if we're thinking about, one of our goals is really to augment an offline OBGYN experience, and one of the ways we're able to do that is by establishing a consistent relationship with a user who's going to see a different provider on Maven, and they might be able to have a conversation with more continuity than you could with an offline OBGYN. And so, for instance, one of the things that we're looking at right now is continuing to make sure that as we develop these relationships, we're enabling users to be able to ask the questions of their OBs so that they're able to direct their care offline too, that they're able to have this centralization of care. So if you're speaking with an OB and a nutritionist and a return to work coach, they're also able to be connected, which you might not necessarily see in an offline setting.
And what do you think the tipping point is for this to go and accelerate from where it is today, from where you are, but also virtual clinics and the space?
I think I would say two things. I think one, overall, just our familiarity and reticence to be able to use telemedicine, I think, can sometimes be a barrier. We found that over 70% of physician appointments can actually occur via telemedicine, so we're trying to take advantage of all of those different opportunities. So as we see user behavior change, and we have been able to see that, and actually just continuing to focus on patient-driven care and putting giving patients the information they need to be able to direct their own experience through a maternity process. I think one thing that we would love to be able to see is obviously Maven in the hands of a variety of users, but as we continue, for your tipping point question, I think is really continuing to invest in the user as that center of care and being able to really direct their own experience.
So when you think about entrepreneurship and startups and innovation, this is about the last industry you'd go into if you want it to be easy. I want to talk about obstacles, the biggest challenges, not the execution that every company has, but the unique challenges that each of you are having executing on what maybe friends or people you're reading about in other industries just don't even have to think about. So healthcare being unique, what's the biggest challenge of all the challenges?
Okay. Well, so I mentioned earlier that Oscar has just hit 1,000 employees. Despite that, we've worked really, really hard to maintain our startup culture and to be very fast and nimble and flexible and iterate quickly. But I'm glad that Joel is here today because probably our biggest challenge is the regulatory environment. I mean, it's not shocking. We are sort of at odds with it philosophically because we want to do a lot of experimentation and sort of try different approaches to certain problems as opposed to having a very prescribed solution to a problem. And so I can give a sort of funny example of the type of thing we deal with all the time. So we have in our app, we have a sort of core entry point into the app is a global search bar, kind of like what you see on Google, right? Pretty straightforward, people know how to use it. But yet we have certain regulatory requirements, and an example of one of them was that we must provide instructions, written instructions on how to use the search. And so we literally have to have a pop-up that says, type in your search and hit search, you know? And it's very intuitive and obvious, and we spend a lot of time on user experience and making sure that it's easy without instruction, but yet we must add the instruction because the regulators want us to. And so, you know, the good thing is we know that we have aligned intentions, right? The intentions are to do right by the consumer, and that's what we want too, and the only difference is how you achieve that. And I think we are very sensitive and aware of the fact that historically they may not have always had people that had the same incentive, and so they found, you know, they often found themselves in a position where they had to prescribe certain mandated approaches, and so that is a challenge we just continue to navigate, and sometimes we are able to make a lot of headway when we kind of discuss the problem and, you know, explain our approaches and sort of align on what we're trying to achieve, but it definitely can slow us down from time to time.
So I got to flip back to you on that because it's a setup for, you know, one of the things we were talking about, you convened not that long ago.
Yeah, I mean, we could honestly sit here all day and talk about these ridiculous regulatory requirements and laws that Congress has passed. I'll give you another one. We brought 10 companies down.
We got the bloggers
Here we
keeping
go.
a list of all these. So.
We convened a bunch of folks from New York in the startup community and brought them down to DC just last week to meet with decision makers in Congress, the White House, the administration, to talk about some of the things they're working on and some of the challenges they face. And there's one guy there, and he brought this little form with him everywhere he went. It's called a CAPS survey. It's a patient experience survey, and you fill it out on paper, and you leave it with the doc or the hospital, or you mail it in, and you can't fill it out by smartphone. It's a regulation that says you cannot fill this survey out by smartphone. And there's an OMB control number on the form, and it's got to all be paper. When I'm assuming when they get it at the office, wherever it goes, they sit there and they type it into the computer, right? Like it's the dumbest thing ever.
Typewriter.
And I guarantee you, it would take probably 3 or 4 years just to change that one regulation, because there's a powered incumbency that makes it beneficial to them to keep things kind of complicated and Byzantine and rely on regulatory capture to say this is the way it's got to be. That disadvantages startups in a big way because we don't benefit then from the fresh thinking or the innovative and creative ideas to blow the doors open. I mean, I'm just talking about a stupid survey, an important survey, so I shouldn't say that. It's an important survey. But for the things that you're trying to do at Oscar, to create concierge care because healthcare is so personal to the individual, you've got to deal with your state insurance commissioner, you got to deal with your federal rules, all the Obamacare rules, you got to present your product in a certain way on the exchange, and you're dealing in maybe in Medicaid, getting into it in the future and all that stuff. I mean, it is crazy what we've set up. And so I agree with you. I think maybe stick with the gas station pump video screens and get out while you can. So it's a problem.
Yeah.
Yeah,
So
big problem.
you know, you talk about reimbursement now for virtual reality, and maybe you've named a couple of the obstacles, cost and the actual device itself being a big problem. What's your biggest challenge? And again, you're the entrepreneur on the stage with, like me, the hat of anything's possible, but then you actually
Then
wake
you have
up
reality.
and you have reality in the sector. So tell me about that.
So it's threefold. One is, you touched on this a little bit. First of all, this is the most complex industry I've ever come across in my life. And generally speaking, I know how to build businesses. I'm a serial entrepreneur, built and sold companies. And in healthcare, it is just, there's so many different pieces that you have to understand. Even when you think about how many different payers there are that you got to go out and try to strike deals with, whether they're self-employed, self-insured employers, or you're thinking about CMS, or you're thinking about some of the big national ones, even the national ones, like take Blue Cross Blue Shield, you think they're national, but some of them are regional, all regional. Some of them cover these states, some of them cover those states. So we want to go in and try to get something across the entire system from trying to drive that scalability and get that velocity. You can't do it that way. So that's one. Second one is the way we think about healthcare today. We always tend to focus on an indication. And I think this comes from a regulatory perspective. When you're going to go through FDA clearance, they say, what is your indication you're going after? Well, if you're thinking about chronic pain, some of the other chronic disease conditions, there's a huge degree of high degree of comorbidity that exists. So that chronic pain sufferer who may have fibromyalgia or lower back pain, they also suffer from depression, anxiety, sleeplessness, catastrophization, poor nutrition, and a bunch of other issues. And so if you really want to address chronic pain, it's not about simply saying, I'm going to do something that solves your pain. I need to solve all those other elements around it. But our healthcare system is set up for what am I going to reimburse you for? Which indication are you going after? And so I was curious when Sara had mentioned this earlier, thinking about, and also what Maven's talking about is taking a much more integrative approach to the way we think about healthcare. That's ultimately how we're going to really impact a lot of these chronic disease conditions that we have in America and quite frankly, globally. But the insurers have got to get on board with thinking about it that way. And I do think the value-based system can start to go in that direction, but even there, I feel like it's still years and years and years away before we get to the point where it's something that is adopted at mass. So it's the opacity, the indication-specific way we think about business, and then it's just changing standard of care, right? I mean, when you go in there and you want to try to get doctors to do something new, it's a long haul to get them to change the way that they have done their business for the last 10, 15, 20 years. And so this industry, more than any other industry, I think really requires partnerships, whether they be KOLs or they be the regulators, or it be the insurance companies or advocacy groups, patient advocacy groups. You need to go out there and strike partnerships in ways that you never would have thought you needed to before.
Harder than gas stations.
Slightly, just slightly.
Katie, biggest obstacles?
Yeah, I think for us it's also regulatory, probably not shockingly. I mean, we are operating a telemedicine network, and it's essentially operating in the U.S., 50 different markets with 50 different states. And so, just to give a very specific example, we see a different concentration of mental health providers across New York, New Jersey, and Connecticut in terms of providers, oftentimes that are well rated. We have a large number of them on our platform in New York. We can't serve the users in New Jersey, who is like a stone's throw away, with those providers in New York. So I think, especially now, we've grown up a bit since our early days, but to your point, I think, especially as an early stage company, it was one of our largest areas of spend just getting off the ground was investing in regulation and making sure that from a PC structure, we've also invested particularly well in the actual healthcare element of what we're doing too.
Okay, so now bringing it back to today, what's the biggest thing in 2019? If we're sitting here a year from now, when we're sitting here a year from now, what's the biggest leap forward that each of your organizations are making? And Joel, the additional perspective you have is multiple organizations that you're kind of working with, both in your kind of collaboratory, but also as your partners. So I'd love to just tap into a little bit over the next year, and then we're going to go long, but I want to go just 12 months right now.
You want me to start?
Sure.
So we are going into a few new states next year.
How many states are you in now?
We will be in 2019 in 9 total, and 14 cities across those 9. So, we have pretty aggressive expansion goals, mostly because we just want to make our product available to more people. And so, we were just talking a lot about regulation. For us as a carrier, in order to go into a new state, it's a whole process. We have to file for licenses, deal with a completely new set of regulations. It's like a lot of overhead. And so we try to expand our footprint as much as we can year over year. And then, we'll be preparing for our Medicare Advantage launch in 2020. And then, luckily, I represent the technology side of the company. Product sits on the technology department. But we recently raised about $375 million from Alphabet. And a lot of that is going to go towards really building out our technology capabilities and investing even more in the consumer experience. So that's going to be my world, is consumer experience and how we can really continue to act as the entry point into healthcare and really create a great experience for both planning and getting care for our consumers.
I'm just going back and forth to the different sides. Matthew.
Our 3 primary initiatives are, one is we've got a chronic pain application that we've been in testing with a bunch of different players. It uses your own bio data to actually drive the experience. And if chronic pain is something that afflicts 100 million people in the U.S., 1.5 billion globally. So that one will be launched and out in the market. And 2, we will have a couple payer relationships that will be locked down. And 3, we will have clearance on a product. So.
Excellent. Joel?
We've got 3 primary initiatives next year too. On the issue side, our core priorities are interoperability, telemedicine or delivery of care, clinical data policy and data use, privacy, et cetera. But I think the area that we're going to have the most impact is opioids. And that's really information asymmetry and providing point of care information on a patient history whether it's prescriber or pharmacist, to prevent bad scripts and to facilitate people who need their medicines. But that's because the political environment, I think, is going to be pretty difficult next year and heading into 2020. So it's the one that we think we can have the biggest impact. We're also rebranding. I'm not going to tell you what our new name is yet, but we'll be
Perfect branding opportunity.
rebranding at HIMSS, and anyway, it's a February thing. But the one I'm most excited about is we've been doing a bunch of trips out to Palo Alto and the Bay Area and up to New York and bringing people here in DC. And what struck us was that there's so much creativity, energy, resources getting put in through the startup effort that we really need to create a startup policy incubator. And we're going to be bringing together startup companies and funders together that decision makers can bounce ideas off of and serve as kind of a policy incubator, not a technology incubator, but a policy innovator that we can then refocus ideas back to the decision makers to say, do this, not that.
Sorry, this made me think of one thing. I was having a conversation with one of the major VCs in healthcare. And if you think about traditional technology, I mean, Elon Musk wants to get away with this whole idea of IP. And it's all about execution and how you build the network externalities and all of that, and how you can get the data and leverage the data to do different things with it. The traditional healthcare investor, they think the exact opposite. They think all about what is that IP that I can get on this asset, the molecule. And so especially when you think about, and this is all digital therapeutics specifically, but they think about what is that IP that I have around this molecule that you've created, and how are you going to go out and monetize it, because you've got a big defense over 17 years for that. And so in the world of digital therapeutics, which is somewhat unique in digital healthcare, it's interesting to see how these two sides, so they have the traditional VC investor, doesn't understand the first thing about healthcare and they don't want to touch it. You have the healthcare investor who wants to have a patent around something, but that's not the world of technology, you just don't do it. And so they have a hard time understanding how do you drive success with something that is, you can build a defensible moat. And so I think right now there's a lot of stuff so back to your comment about how do you go out and you have an incubator that can bring those two sides together. I think that'd be beneficial to the industry, at least for my section of the industry.
Yeah, I think for entrepreneurs, and we have a community of about 500 entrepreneurs from 250 companies in 20 countries. And what we've seen is linking the entrepreneurs together so that they don't feel alone anymore, because it's lonely being an entrepreneur anyway, but in this sector, you just get beat up every day, and the rejection and the obstacles and all those things. And so when you start to connect everybody together and then represent kind of a conversation where it's not just feeling like you're hitting a wall, I think a lot of the progress that everybody is trying to make. I mean, there's 10,000 of these kinds of companies around the world trying to innovate, trying to save lives, trying to improve lives, but regulation and bureaucracy, and imagine if CBS, ABC, and NBC were stopping new content from being created and there was no Netflix or Amazon Prime Video. So there's that innovation being stifled by a lot of that, which is there to protect. But that conversation is an important one.
And can I just add to what I said? So the regulatory science, and this administration has been good about this, trying to get better at the regulatory science and speed up that cycle, but the cycles are still misaligned.
Yeah.
And so I think that having this community come together to inform that process should clear away some of these regulatory challenges that everyone's talking about.
If you have the right mindset, and I do believe that Scott and Bakul and all of them have the right. Yeah, they have the right mindset.
Yeah, absolutely.
Yeah, mindset's actually my next question, because that's the biggest challenge everybody's facing. But Katie, when you look at the next 12 months, and then you look at the series of things that if you look out 5 years from Maven, what you have to have in place now that sets you guys up?
Yeah, so I think, the benefit, I think, is that we are largely competing against the status quo, in the sense that we oftentimes are competing against maternity management providers for insurers. So we have a large opportunity ahead of us to continue to just innovate in our core product offering, which is really a digital solution for maternity, fertility management, and want to be able to serve all types of families no matter how you get there, whether it's adoption or surrogacy. We just launched Maven Milk, which is a breast milk shipping service as well. So, as we're thinking through kind of the counterpart from the fertility side to ultimately returning to work, how do we ease that experience for working mothers? And I think, where I see ourselves going in 5 years, I think one thing we can continue to innovate on, and I would love to be able to see us do more of this, is thinking through the remote monitoring. I mean, we have devices that have been in place for tens or decades, I guess at this point, but like a blood pressure cuff if you're trying to manage high-risk pregnancies. But I think the key there is, how do we continue to get that data back to Maven, back to the providers, such that we're able to make actionable decisions. On the other side, we have technology that is just starting to be used, which is like a little patch that you can put across the abdomen that will monitor intrauterine contractions, so as you're going into labor, so we can help understand whether it's actual preterm labor or if it's not. So I think there's a lot of promise that we can continue to have in terms of even what we are able to do as a technology company in this space.
So we're going to have microphones. I think in like 3.5 minutes, there's going to be microphones. If you guys have questions for the panel, it's going to be your chance to ask. So just by a show of hands, because I want to see how much time we need to leave for questions over there. You know what? Can we? Do we have the microphones now to do this a little early? Yes? No? Yes. All right. So gentleman over here first, who has his hand raised. If you could just introduce yourself and then direct the question.
Thank you. My name is John Birch. I'm an angel investor in Kansas City. I have a question about software as a medical device, which really hasn't come up, but it was just sort of parenthetically referred to. The pre-cert program that the FDA is running is the way they have, or the way they initially did it. Just for clarification, it's a program to essentially, instead of testing every new version of a piece of software that is in healthcare, you certify the company that makes it. And they don't have to test every new version. Nonetheless, it still is something of an obstacle to very small entrepreneurs. I was wondering if, from a regulatory point of view, you might have any thoughts about what we can expect there. A $3 trillion industry, approximately half to 2/3 of which cost goes into human labor. Cognitive automation, the ability to automate some of these thinking processes and information processing is absolutely the key to bringing down costs and yet allowing care to improve. So what I'm asking about is a crucial thing going forward.
Yep. Joel?
Yeah, we worked on the law actually that was kind of spurred some of that thinking at FDA, and it was called MedTech in 21st Century Cures. And the way I think about it is kind of like a TSA pre-cert program, and if you think about it that way. So I think the results are still yet to be written. Like, we don't know yet exactly how good it's going to work. I think another way to do it would be to say, for the low-risk technology that, for example, is not touching the patient, or that is connecting provider to patient, or something along those lines, that we kind of give that a pass through the FDA. And I think that was kind of some of the vision around that. For the higher risk technology, like you've got an app that's triggering, like through a Bluetooth signal, a glucose monitor that is then firing an insulin pump. Well, that's having a direct impact on the patient, so that's a little bit higher risk. And so we're actually going to send that through the FDA process, but we can do that in an expedited manner because we know what Bluetooth is. It's built to a standard. And because it's built to a standard, then we can measure good manufacturing processes and then kind of expedite that whole process. But if it's something like totally mind-blowing, we've never seen this stuff before, maybe then we send it through a longer review process at the FDA. So I think tying it back to risk is really the more appropriate path. And you can develop good regulatory science around that path to say, if your app life cycle is a 3 to 6 month life cycle, we ought to have a regulatory process that makes sure the regulatory process is not longer than the app life cycle itself, right?
Just startup is never going to get pre-certified.
Well, so actually there's two different things. Pre-cert is different than actually getting SAMD clearance. Pre-cert is basically the good manufacturing housekeeping seal of approval. The SAMD clearance is around effectively what indication, goes back to that indication. What indication are you going after? And its risk is one thing. The other element of it is what's the claims you're going to make. So am I trying to manage something, or is it a relaxation, or am I actually relieving pain, and put it in my world? So we think about this every day, and unfortunately, it's something that we have to go through. Just one other quick comment on this is, I think in the app world, there's something, I saw a stat, there's something like 10,000 smoking cessation apps that are out there. When you think about this from a confusion in the marketplace for either a patient or a provider, they have no idea which one of those that they should go with, because there's no real filter around this. And that's the positive side of the regulatory environment right now, is if you can engage with these people that are actually very proactive about it, you can help create a world where they are faster about doing it. And it does create clarity for the clinicians and for the patients that patients don't really think about FDA, but at least you can make a claim around it that says, I am solving this, or I'm addressing this. And I do think it's important to have that type of clarity.
And at the end of the day, it's a trade-off, right? We've said we want a safer system, and so as a result, it's going to be a harder process, and so some money is not going to get invested in those products, and we'll never know the impact on our health system. But that's kind of the trade-off that we've made, and what we're trying to suggest is, can we think around that barrier to have a faster process so that we actually get those products built? And I think there needs to be some better thinking there. That's why I go back to the incubator idea. Yeah. Let's figure out what that is.
And it wasn't that long ago there was no conversation with the FDA or anybody in the government. It was literally a 1 year, their review period of figuring out what to do. So we've come a long way.
They didn't want to touch apps for a long time.
Right. So we have a lot of questions. Who's got the microphone? Yep. So up here, this cluster, there's 3 people. Yeah.
Thank you. George Mesregos, Children's Hospital of Pittsburgh. Can you speak in terms of digital health for children or adolescents? In our world, we sometimes fear that where children could lead the way or have applications that could lead the way, sometimes they're left behind. And maybe if Matthew or the rest of the panel would speak about the pace of progress for children in terms of digital health.
So actually, in the world of children's health, we've been fortunate. I think we're in over about 250, 300 hospitals right now. Majority of them are children's hospitals or pediatric wards for being used. And in fact, there was someone tweeted today the use on a child that was going through incubation, and they put our headset on them to help them through that period, so they weren't freaking out. The one challenge we have in this case is if you go back and you say, okay, from a consumer side, VR is supposed to be 13 and above. Why is it supposed to be 13 above? Oculus was bought by Facebook. Facebook has an age restriction of 13 for it, and so Oculus adopted it, and so any other VR company effectively adopted that because of Facebook. So for us, it's about trying to help demonstrate why it's okay to be using this on children. And then the other element for us personally is that these are short-term interventions. When you think about what Achille is doing as an example with ADHD, they're going through that FDA process right now, and they're in their pivotal trial, I believe. But they're doing some great work. And I think there's, with children, anytime you can help them not use sedation or any type of morphine equivalent, that's a good thing.
Yeah, Children's Health is one of our 10 moonshots, and we're tracking hundreds of digital health and digital therapeutic startups focused on children's health. What I can tell you is, and Susanna Fox, I don't know if she's in here, but she was in the lunch panels, an old friend who talked about how it's just the way they grew up. They all use health apps, and obviously if you're around any kids, you know that they're always holding their phones or their devices. And so expectations are completely different about it not being just going to get traditional medicine or even any of the things that I think entrepreneurs are trying to kind of get into market today. So children's health in multiple levels, I think, is a big deal. Obviously, starting in utero, which is where Maven's starting, is a place to start it, which I think is key.
Yeah, I was just going to add, and we do early pediatrics on Maven as well, and what we oftentimes see is that for ER visits for children, they're urgent, but oftentimes not necessarily warranted to go to the ER, and yet parents take their kids because it's after hours, it's on the weekends, it's the most effective, they think, thing to do. But oftentimes with a short video call with a telemedicine provider can actually alleviate some of those concerns in a way that doesn't also expose your child to germs they might pick up in the ER too. So we do see a large uptick there.
Yeah, we have an interesting company called CareDocs, which is actually, nobody realizes that schools are the entry point of all of the medical records of children because of everything that happens each year, and it's kept up to date. And they've standardized and built a platform for schools to standardize and make it easy to get everything from the doctor. So there's, like every other part of the sector, there are hundreds of entrepreneurs descending, yet going back to regulatory, is where are they stopped and have to go through and get slowed down in that. Do you want to add something, Sarah?
Yeah, I'll add. So at Oscar, we also have a pediatric virtual telemedicine benefit. And what I find really intriguing is, as a mother, I can tell you, like the amount of times that my child has had a fever and a simple little device to look in their ear would have told me easily that they had an ear infection and needed antibiotics, but I must go travel God knows how far to see a doctor to find that out. What I think it's a very good intersection of all the things we've been talking about wearables and devices, and I think the future hopefully will hold, a lot of advancements that will make it much less painful for people to get basic care for their children. And so maybe the children, not necessarily themselves interacting with the digital devices, but also enabling the families and the parents to have more accessibility and convenient access to the basic care, I think has to be what the future holds.
Excellent. So we have a lot more questions right behind the gentleman who just went. Right, perfect. Thank you.
Hi, I'm Lucia Savage. I'm a
Can you
healthcare.
stand up, please? Thank you.
I'm Lucia Savage. I'm a healthcare regulatory lawyer, and of course, you all talked about regulations. But I want to know, people really sort of tag whoever the marquee agency is this year. It happens to be the FDA. So I have kind of a two-part question: who federally could be doing better in interacting with the digital innovators? And secondly, what's the plan for the states? Because honestly, they're like 12 years behind everybody else.
I have a bias here. I think that, you've got multiple departments and multiple agencies within those departments working on technology and innovation and patient care and other issues. I think there ought to be a convener outside of HHS at the White House level. And I think that's OIRA, which is the Office of
Institutional Research and Analysis.
No. Regulatory Affairs. I forget what the I stands for, but it's within the White House. It's a sister agency to the Office of Management and Budget, and they basically, all the regulations kind of flow up through OIRA, and I think they should be the coordinator, and there should be a central organizing theme and principle at that level that says we are going to promote innovation. We're going to have a safety standard. We are going to have regulatory burden reduction as a core tenet. I think ONC has done a really good job at that, but I think that they're hobbled by the fact that they're within HHS, and we need something that's above HHS and VA and Commerce and all these other department level entities, so that it's kind of going up and then on to the president. States, it's got to go through CMS, because I think that's where the money comes, and the states respond to money. They medicate, they educate, and they incarcerate, and so you got to go through one of those three, and that's how you're going to change behavior with the states. So through CMS.
Back there.
Hi,
And we've got like 7 minutes, so we're going to do some speed rounds of questions so we can get to more questions.
Yeah, Hoyt Morgan from
can
M
stand
Square
up, please.
Healthcare. Quick question for Matthew. As you build your reimbursement case, what are the most important and effective factors? Is it the equivalent cost of opioid drugs? Is it the development cost? Is it how much money you save for people not getting addicted?
It's about resource reduction, resource utilization reduction. That's how we think about it. I think anyone that's coming into healthcare, you've got to be able to demonstrate, because right now payers, and no offense to Oscar here, because we're going to go Oscar, by the way. Payers, they think about this as, I'll take the same efficacy at a reduced rate, or I'll just take a reduced rate. And they don't necessarily care about what's the benefit and outcome if it doesn't mean a change in pricing for them. So you really just got to think about, can you come in and actually make drive a reduction in resource utilization? That's what we completely focus on. So whether it be sedation, that's why I also think at home, if you're going to go somewhere, if you can go into the home and make an impact there and demonstrate that economic impact, it's huge.
So 3/4 of the way back. Yeah, the light's shining, so I can't see. There you go. Thank you.
Hello, Paul Anthony. I'm a physician and a user of these types of tools, and I'll say, on the whole, I find them very helpful, and they improve the quality of care. When I get replaced by them, I may have a different point of view. But my question is actually about data standards, and whether we're moving towards kind of a single standard for sharing the data, or is there going to be a Google standard, an Apple standard, and someone else's standard? And any comments on HIPAA's helpfulness or not helpfulness in that? And then, if you'll indulge me, my last comment is, as an actual user of these tools, there is a lot of garbage in the electronic medical records that I use, just trash, it's just clearly wrong. So before you replace me with some kind of algorithm, please make sure that the data actually reflects what's going on in the patient.
All right, so who wants to take the data question?
I think data is going to have to ride above the whole thing. I know that the FDA actually, I believe, is working on that with one of the big consulting firms, and because we have to be able to get data regardless of where it comes from. And so we ourselves don't think about ourselves as Apple or Google or anything like that. It's just having that layer over top. It's like where you have Redox and companies like that are sitting in between the EMRs and other applications, or Zelth is another example of that. That's enabling them to ride on top so that it doesn't matter who you are, but you can plug into it.
I'm less concerned about the actual standards for the data. I think it can be converted and normalized and all the other things that can be done with data these days. I think that it's more about business practices that institutionalize data hoarding and create incentives to not share data. And we're very excited that an information blocking rule is about to be released by this administration that's going to say, in an information sharing program, it should be a no-no to block information, and that's probably a bit overdue. But the other question relates to HIPAA. I'm embarrassed to admit I'm old enough to have been like year 2 in Congress when HIPAA was passed, and I did some of the work on the fraud and abuse provisions of that law, but then afterwards worked with a bunch of House members who are now senators, so that tells you how long ago that was, and we were working on these things called green screens. Right? If anyone is old enough to remember those, they were like, back in the back. No smartphones, no iPads, no societal movement towards Facebook where as a culture we've said it's okay to throw our own data out there, but just don't lie to me about what you're going to do with it. Right? And I think so we've come a long way, baby, from HIPAA 96 to 2018, but our laws haven't kept up or evolved in the way that I think they should, and our culture has changed. So we need to take a fresh look at HIPAA and a fresh look at how we're treating people as they use and interact with their own data.
Anish Chopra's talking tomorrow. He's FHIR, F-H-I-R. He's a big advocate of standardizing data, and I believe on tomorrow's panel, I don't know what time, you should go see him, because this is a wealth of, and opening up a can of worms in terms of conversations. The big thing is the APIs, right? Just being able to talk to each other. I know that my iPhone imported everything from my MyChart and Epic and all this different stuff, and so you start to look at it and go back to the junk. It is absolutely a moment in time where we get to see what everybody's got on us, and it's kind of scary and inaccurate. We got two more questions? Yes? Okay. Right up here in the middle. Sorry.
I appreciate it. Hi, I'm Lisa Fitzpatrick. I'm an epidemiologist and new physician entrepreneur. Before I ask my question, Matt, I think the gas station ads are a great opportunity for health literacy, especially in the communities where I work. So I'm going to look into that. But my question is...
I know someone who can help you out.
Awesome. I love hearing about these innovations, but I work in low-income minority communities, a lot of Medicaid patients, and I don't see any of these technologies or innovations with the patients I serve or the communities I'm walking in. So what are your... how are you implementing or enabling access to these tools for low-income or poor communities? And if you're not, what's the plan to do so?
Katie?
Yeah, sure. So I can talk a little bit. I mean, we actually, on both our direct-to-consumer and our employer model, we see patients from across a wide range of socioeconomic status actually use Maven. We have looked to see what type of device oftentimes is most effective, and so whether that's an iPhone or an Android device, that's been an important consideration for us. But really, our employers span from Fortune 100s that are largely a higher socioeconomic status, maybe a white-collar workforce, to employers who are more union-based and our patients are actually using this who come from a more disadvantaged background. So it's really been a mix from across the board, and I think as we continue to expand, we'll be able to learn more of what really resonates with different types of populations.
So we have, do you want to add something, Sarah?
It's okay, we're in a rush.
Go ahead. We have time for one more question after you answer.
Okay, I just wanted to add something quickly. So one thing just that I find interesting about Oscar is people often perceive us to be sort of tailored towards young, higher income, healthy, cool hipsters. That is definitely not what we see in our actual population. We have a lot of diversity in our population across age, across clinical profile, across socioeconomic status. And what we try to do is make sure that for people that are less digitally engaged, for whatever reason, some people don't have smartphones, for example, that we have alternative manners of really engaging with them. And so, for example, we invest a lot in our concierge teams, which is our customer service model, where every member has a dedicated set of people that they can talk to every time they contact us, that they get to know, build a relationship with. They can do it through messaging, they can do it over the phone. And what we focus on from the technology side is really empowering those teams with the right tools to be able to create the same kind of engagements and interventions with that population as we can do digitally. So that's another way to really address people that have different, things available to them at any given time. And what we see is that our engagement levels are pretty consistent across all those cohorts as a result.
Awesome. One more question up here, second row. Thank you.
Hi, Mike Goodman. So I was curious, especially for Oscar and Maven, what do you guys see as your role in terms of interacting with the patient's physician? Because a lot of what you do goes direct to consumer, provides value. You provide a whole care team, right, outside of an individual's doctor, which is great. Some people could say it's interfering with the doctor-patient relationship. So what do you do with an individual patient's doctor, and how do you perceive that evolving over time?
Yeah, I'm happy to start. I think, one, we view our role as very much kind of side by side with an offline OBGYN. Clearly, we're not delivering babies and doing ultrasounds virtually. So, but I think, in all seriousness, we are really focused on giving information to the patient, and having just been a pregnant person myself, I understand that there are conflicting pieces of advice over whether or not you should drink a glass of wine, or whether or not it makes sense to do X, Y, or Z. And so being able to basically use that information as a patient. I've also used Maven, to be able to ask questions that as a kind of a second opinion, or thoughts of things I would want to ask my offline provider. So how do I avoid a C-section? Having that conversation multiple times can actually be really beneficial. And we give the data to the patient that they are able to then have that conversation with their offline provider as well. So they're not in the dark about what's being said about them with a practitioner that they may have seen through telemedicine.
Sarah?
Yeah, I'll add quickly. We also really believe in the partnership model. So for us, it starts with picking the right providers to partner with, right? We're an insurer, so we have to build a network that is available to our members. And so both on the system side, we usually anchor our networks around a particular system that we have aligned philosophies with. We usually have aligned incentives with some risk sharing arrangement, and that we believe is high quality. And then it also extends to the individual providers, where we really try to pick high quality, high value, so low cost, high quality providers that we center the network around. And then what we do is we steer our members, because of our engagement, we're able to translate that, help guide them to the right care to those high value providers. And what that does is it fills up their panel with more and more Oscar patients, which then makes them want to work with us more closely. So it's sort of this closed loop that we create with the doctors, and we don't believe in really trying to influence their clinical decision making, but more so things like how they route within the system, and whether they're sending the lab to the hospital or to a Quest, and making sure that they're making cost-effective decisions, as opposed to whether they should have diagnosed someone with something. That's not sort of the job we feel that we are taking in this game.
Awesome. Thank you. We're going to do a quick one-word close. Last word on the panel. Each of you pick a word.
One word?
One word that represents the last hour and what people should remember about you. Joel?
Oira? No. Disrupt. Disrupt.
Hope.
Cross-functional.
Frictionless.
Inspired. Thank you very much.